users, and then describe a pharmacist-led weight loss clinic developed for transplant patients who have been denied transplant due to high BMI. But first, we wanted to discuss how obesity can impact transplant outcomes. Obesity is associated with an increased risk of many things, including delayed graft function, wound complications, prolonged hospitalization, new onset diabetes, biopsy-proven rejection, and overall reduced graft survival. These higher mortality rates in obese renal transplant recipients can be due to many different things, including increased rates of postoperative cardiovascular complications, such as AFib or congestive heart failure. Evidence so far does not support using a strict body mass index or BMI cutoff to not deny someone candidacy for transplant, but obesity is frequently associated with other conditions that may be contraindications for transplant, such as cardiovascular disease, cancer, renal dysfunction, and pulmonary hypertension. Obesity is also a risk factor for non-alcoholic fatty liver disease, and these patients have lower one-year post-transplant survival due to cardiovascular and cerebrovascular diseases. Recognition of associated complications has led to obesity becoming a relative contraindication to renal transplant. A BMI of 35 to 40 has been suggested as an upper limit for transplant candidacy, and guidelines issued by AST recommended a supervised weight loss regimen, which really should include things such as a low-calorie diet, behavioral therapy, and a physical activity plan. Some kidney transplant programs will often require that obese candidates meet a specified BMI and or weight loss criteria, such as 20 or 30 pounds from their baseline prior to being approved for listing. However, the recent SRTR data has shown that obesity is the third leading cause of being inactive on the kidney transplant wait list. Patients with obesity have a reported lower likelihood of transplantation when compared to patients with normal BMI, and patients with morbid obesity have a higher risk of dying while on the wait list. Some liver transplant programs consider morbid obesity a relative contraindication similar to kidney transplant patients. Over 50% of institutions do list obese patients, with around 55% reporting that their BMI cutoff for transplant was 40, but a range of 35 to unlimited has been noted. And these patients with a higher BMI were less likely to be evaluated for transplant due to potentially the reported increased complication rates among these patients, such as poor wound healing and increased infection rates. Interestingly, this also has implications for living donors as well. Patients that are rejected from living donor liver transplant programs due to an unacceptable graft weight to recipient weight or GW-RW ratio have higher BMIs. Obese recipients may need livers from donors with higher BMIs to account for this ratio. And so thus, donors may be at risk of being a higher risk of being turned down due to non-alcoholic fatty liver disease. Obesity can be measured in a couple of different ways. We have the body mass index that I've been talking about with this different classifications, all the way from underweight up to obese class 3. But we also have central obesity and a way to define that, which is important, especially with our abdominal transplant patients, which is the waist circumference that can also increase the risk for weight-associated diseases. So for males, greater than 40 inches of waist circumference, or females greater than 35 inches of waist circumference can increase the risk for weight-associated diseases as well. There are several pitfalls of BMI, especially in the pre-transplant setting. For example, sarcopenia can actually outperform, or has been shown to outperform, BMI as a predictor of outcomes after transplant. Cross-sectional imaging of body composition has found that sarcopenia and low subcutaneous adipose tissue is actually associated with mortality in male and female patients with cirrhosis. There is a protective association of higher BMI with survival in hemodialysis patients and is limited to patients with normal or high urinary creatinine excretion. However, in contrast, dialysis patients with a high BMI, low muscle mass, and thus inferred high body fat had significantly increased mortality compared to those with a normal BMI. Additionally, BMI really doesn't give much information about body composition. For example, the central obesity measure is not exclusively correlated with a BMI. So you cannot also tell the difference between muscle, subcutaneous, or visceral adipose tissue. And then finally, fluid shifts can be a significant contributor to weight, which is not accounted for in BMI. A higher BMI may be due to fluid overload or ascites, but adjusting BMI for the liters of ascites drained at the time of transplant actually resulted in moving 1/5 of patients from one BMI category to a lower BMI category. There are some current available weight loss strategies for pre-transplant candidates. The first and important one is dietary changes and monitoring recommendations. Patients with a BMI greater than 35 are recommended to at least receive dietary counseling prior to transplant. They should be reducing calories from carb and fat content while still maintaining high protein intake. They should have target daily energy intake goals, and hopefully to prevent the reduction of muscle breakdown, patients should also avoid prolonged fasting periods, such as intermittent fasting. There are some specific things to consider, particularly in liver or kidney transplant recipients or waitlisted. For the liver transplant patients, the increase in hepatic venous pressure gradient occurs in patients with cirrhosis and portal hypertension anytime they're doing physical exercise or activity. So before these patients with cirrhosis potentially go into an exercise program that might be suggested prior to transplant, the indication for prophylaxis against variceal hemorrhage should be determined. Additionally, the adequate intake of proteins and nutrients to promote reduction of fat mass, but not worsen sarcopenia, is of importance. The exercise program should be feasible and beneficial, but strictly supervised and required individualized attention for each patient. For kidney transplant recipients or candidates, current recommendations include aerobic exercises for 30 minutes most days of the week, but there have been studies to suggest there are several identified barriers of exercise, such as tiredness, muscle fatigue, fear of arteriovenous fistula injury, and potentially hypotension after hemodialysis. We also have pharmacotherapy options in addition to dietary counseling and exercise, which we will talk about shortly. And then we also have weight loss surgery. There are a couple different options for weight loss surgery, including bariatric surgery. However, the ideal time regarding liver transplant with bariatric surgery is really unknown. We also have the option for a sleeve gastrectomy, which has the best evidence specifically with liver transplant, but there may be a lot of hesitancy with patients about an additional surgical procedure that's needed, and insurance coverage may not be guaranteed with this procedure. The use of bariatric surgery has been relatively uncommon among kidney transplant candidates and recipients despite their otherwise qualifying indications. So there's really not as much evidence about weight loss surgery as we would like. There's also many pitfalls of diet and exercise alone in the setting of end-stage organ disease. There was a study that conducted interviews with patients that were required to lose weight to achieve eligibility for kidney transplant and their experiences of weight loss attempts as they were working towards that goal. There were four key things noted, but the first being restrictions and exhaustion. It was difficult for the patients to adhere to the dietary restrictions given the limitations they have with their diet being an end-stage renal disease patient. They are having a hard time adhering to these diets while also having to lose weight. Additionally, patients reported extreme levels of exhaustion. They are trying to potentially carry on their normal family and job responsibilities while also going to dialysis 3 times a week, and then also trying to implement these dietary and exercise restrictions. A lot of patients noted both hope and hopelessness throughout their weight loss journey. Patients described weight loss endeavors can sometimes feel all-encompassing and hopeless, but the hopelessness was something that they could rarely continue for too long, and they would often try to turn it around to feeling hope towards their goal. Words expressing feelings of having to lose weight by patients included impossible, things like calling it a battle, and that it may not even happen for them. Support from both the transplant center and family is extremely important because patients often felt like the personal responsibility of weight loss was really ultimately something that only they were able to accomplish, and no one else could do that job for them. And then finally, an interesting point from the survey was motivation based on severity of weight loss or perceived severity. Patients did not necessarily feel much urgency to lose weight because their illness was not serious enough yet. There was a specific survey among patients with BMI greater than 30, and over 50% of patients perceived that they were overweight, and 23 of those patients actually believed they were underweight. And then among patients with an elevated BMI who perceived that they were overweight, only about 40% were actively trying to lose weight, and 60% were really just trying to keep from gaining weight. I wanted to provide some takeaways from classifying and describing obesity in our candidates who are being listed for transplant, because really more than obesity itself, it's the sum of the comorbidities of the individual patient that determines the post-transplant outcomes. It shouldn't be a contraindication on its own, but in turn should really trigger a rigorous pre-transplant assessment for these patients. Additionally, obese patients with end-stage liver or kidney disease may encounter setbacks on their weight loss journey through the conventional weight loss strategies and may be looking for other alternatives. Healthcare professionals should be educated to anticipate these challenges and better support patients who are trying to lose weight, which is really where a pharmacist can come in with the options for the pharmacotherapy for weight loss. There are several different categories of medications or classes of medications for weight loss, and I will try to go through each of them for the rest of the presentation. First, we have the list here of the FDA-approved anti-obesity medications, which is important to note when we'll talk about later with covering these medications through patients' insurance. Specifically wanted to highlight liraglutide and semaglutide, who specifically only received the FDA approval at the doses of liraglutide 3 milligrams or Saxenda product, and the semaglutide 2.4 milligrams or the Wegovy product. I'd like to next spend a majority of the time talking about the glucagon-like peptide-1 receptor agonists, or the GLP-1 RAs, as these are the majority of the medications that we will use for weight loss. There are several different available GLP-1 RA therapies. I've listed the most common ones that we will utilize here: the generic liraglutide, semaglutide, dulaglutide, and exenatide, with all of their branded products underneath. Importantly, the GLP-1 receptor agonists have many different mechanisms. GLP-1 is produced specifically from the pro-glucagon gene in L cells of the small intestine, and it binds to a specific GLP-1 receptor, which is expressed in various tissues, as you can see in the picture on the right, which includes the pancreatic beta cells, pancreatic ducts, gastric mucosa, the kidney, lung, heart, skin, immune cells, and the hypothalamus. As you can see here, the GLP-1 RA also can affect glucose control through several mechanisms, including enhancement of glucose-dependent insulin secretion, slowed gastric emptying, and reduction of postprandial glucagon and food intake. And then specifically in patients with type 2 diabetes and cardiovascular disease, there has been shown to be a reduction in ASCVD outcomes when compared with placebo for liraglutide, semaglutide, and dulaglutide. So they can also provide additional cardiovascular risk reduction as well. I just wanted to briefly here list the dosing and adverse effects of these medications. I'll go into that a little bit more, but more specifically, contraindications to the GLP-1 receptor agonists include personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. And as we're probably familiar with, the adverse effects most commonly are abdominal pain, constipation, diarrhea, and vomiting, with hypoglycemia being a little bit lower on the risk. Something that we talk a lot about in our clinic are all GLP-1 receptor agonists equal? There was a nice systematic review that was published comparing a majority of all of the different agents and doses, although the most recently approved medications were not included. I wanted to point out here specifically that semaglutide 1 milligram compared best compared to all other medications, oral versus injectable, and all of their doses. And even semaglutide 0.5 milligram performed better in terms of weight loss in the SUSTAIN-7 trial compared to even dulaglutide or liraglutide. So semaglutide has really been proven to have the most weight loss compared to all of the GLP-1 receptor agonists if patients are able to tolerate it. Next, I want to talk about tirzepatide, or Mounjaro, which is the most recently approved medication for type 2 diabetes. This is a glucose-dependent insulinotropic polypeptide receptor and GLP-1 receptor agonist. It is dosed once weekly and then can be titrated every month. The adverse effects are similar to the GLP-1 RA group, which includes nausea, diarrhea, decreased appetite, constipation, abdominal pain. Of note, this was approved by the FDA in May of 2022 for type 2 diabetes. However, the change in weight was noted as a secondary endpoint in the tirzepatide trials. These included both the SURMOUNT-1 and the SURPASS-2, which was compared tirzepatide versus semaglutide. Tirzepatide versus semaglutide in the SURPASS-2 trial was an open-label trial where patients were able to receive tirzepatide at 3 different doses compared to semaglutide at 1 milligram. Their primary endpoint was the change in the glycated hemoglobin level from baseline to 40 weeks, and the estimated change from baseline in these levels was reduced by 2.24, and 2.3 points, respectively, with tirzepatide at all doses, compared to only a reduction of 1.86 percentage points with semaglutide. The key here was the secondary endpoint, in which the authors of the study discussed the change in body weight. There was a reduction in body weight greater with tirzepatide than with semaglutide at all doses, with reductions of almost 2 kilos, 3.6 kilos, and 5.5 kilos of weight as compared to semaglutide. And this was statistically significant for all comparisons. And then I wanted to show this here. These graphs here show the change in body weight between semaglutide 1 milligrams and tirzepatide at 5, 10, and 15 milligrams. As you can see here in the gray line, which is semaglutide 1 milligram, it showed the least amount of weight loss in change from baseline, as opposed to tirzepatide 15 milligrams, which showed the most amount of weight loss at almost 13 kilos over the course of 40 weeks, which is a pretty significant amount of weight loss for these agents. And again, this was just a secondary endpoint from this trial. I want to also mention pharmacologic therapies that exist in the oral form that can be additional options if patients are not able to utilize the previous discussed medications. I just listed briefly here with mechanisms and adverse effects. Briefly, orlistat will reversibly inhibit gastric and pancreatic lipases, which prevents the hydrolysis of triglycerides, and then free fatty acids are not absorbed. This can be very challenging for patients to tolerate and can induce significant abdominal pain, bowel urgency, and steatorrhea. The phentermine-based products work by acting on the central nervous system to suppress appetite. It has been shown to stimulate the release of norepinephrine in the hypothalamus as well. Phentermine-based products most commonly can cause tachycardia or hypertension. With the addition of topiramate to phentermine, this adds appetite suppression through modulation of the GABA receptor, which causes glutamate inhibition as well as increased dopamine release. We have the naltrexone and bupropion product, which affects 2 separate areas of the brain, including the hypothalamus and the mesolimbic dopamine circuit. And then finally, we have Gelesis 100, which is a product that absorbs water, expands in the stomach and small intestine, which forms a semi-solid gel structure, and may promote satiety and result in weight loss via reduced caloric intake. Most commonly, patients can experience diarrhea, abdominal distension, and constipation. Briefly here, I wanted to list the comparison of the average placebo-subtracted weight loss in percentage with the different oral agents. So phentermine was shown to have about 4.4% of weight loss at 28 weeks. Orlistat was shown to have about 3.8% of weight loss. Phentermine and topiramate, or the branded Kisimia, was 8.6%, and then bupropion and naltrexone, or Contrave, was 4.8%. There was a small amount of studies combined together that discussed glucagon-like peptide-1 receptor agonists in end-stage kidney disease and kidney transplantation. Liraglutide was able to show reductions of weight between 1 and 2 kilos in patients with diabetes on dialysis. In prospective studies with end-stage kidney disease, 12 months of semaglutide resulted in weight losses of up to 8 kilos. And then in retrospective cohort studies, with 12 months of a GLP-1 receptor agonist, some weight losses of up to 4 kilos were described. However, gastrointestinal side effects were most commonly reported, with hypoglycemia described with the GLP-1 RAs in hemodialysis patients, particularly in those using insulin. So ultimately, although these products are growing in popularity with diabetes and obesity, there is not a lot of literature in end-stage populations. However, these observational studies did show modest glycemic and weight benefits. And however, something to consider is that the GI side effects may limit adherence in this very tenuous population. I wanted to show an example of the pharmacologic treatment algorithm that our liver metabolic clinic uses at Henry Ford Health. This is one page of our protocol as an example for how we try to consider which medication a patient should be started on. So for example, and kind of the easiest one for us to follow is if a patient has a concomitant diagnosis of diabetes, or they have an elevated A1C and have not yet been diagnosed with diabetes, we go straight for a GLP-1 receptor agonist or Mounjaro with a GIP and GLP-1 receptor agonist. As I've briefly talked about, they have the best benefit with not only weight loss, A1C reduction as well, and have shown cardiovascular benefit in these populations. Some of the different situations that we get into are patients with existing cardiovascular disease, such as coronary artery disease or heart failure. In these patients specifically, we really try to avoid phentermine if possible, due to the side effects that phentermine can incur. Similarly, for patients with arrhythmias, at baseline, we also try to avoid phentermine-based products. If patients have hypertension, we do ensure that their hypertension is controlled and optimized with antihypertensive if needed before starting on a phentermine or naltrexone and bupropion-based product, but would prefer the GLP-1 receptor agonist in this population if possible. For patients with hepatic dysfunction, we do try to avoid phentermine or naltrexone and bupropion-based products and favor the injectable medications. And then finally, if patients have a history of seizures or opioid dependence, we will avoid the naltrexone-based products as well. I think the most important part of one of the most important parts of the pharmacist's role are the considerations prior to transplant that we take into account when initiating a patient on a medication. So I'll list some of the things that we think about when trying to start a medication. The first being availability. Insurance coverage is potentially a huge barrier. In Detroit, a lot of our patients are Medicare and Medicaid-based patients, and so insurance coverage can be a challenge. Medicare does not yet have a weight loss medication therapy clause included in most plans. So a lot of our patients do not have coverage for weight loss medications. If the medication does not have FDA approval for weight loss, it can also be very challenging for both private and Medicare and Medicaid-based insurances to pay for these medications as they are very expensive. If they do pay for the medications, oftentimes the cost can be prohibitive to our patients. They're often also going through a lot of expensive testing to get worked up for transplant. Their copays be very high, especially if they haven't met their deductible. And so that's where our patient assistance programs can come in. I have an example on the side of a patient application that we will use through a drug company, where if a patient has concomitant diabetes, we can try to get their medication through the manufacturer for free based on the income qualifications, which a lot of our patients do meet. And then finally, one of the biggest things we've been challenged with availability is drug shortages. So a lot of you may be familiar with that these medications have been going on and off shortage with all the different strengths and different branded products. We've had lots of patients that have had to start and stop their titrations because of this, and so that's something to take into account as well. The adverse effects profile is something we'll consider if the patient has a cardiac history, shying away from those medications that can induce further problems versus a significant gastrointestinal history, such as histories of pancreatitis, history of gastroparesis if they are a diabetic patient, or history with significant nausea or vomiting or diarrhea. We may want to avoid the medications with that side effect profile. We also take into account metabolism of the oral medications and whether end-stage disease may require an adjustment in the dosing of these medications. And then finally, drug interactions is something we consider as well. So bupropion and the active metabolites are inhibitors of the CYP2D6 and OC2 receptors. And if these medications are being utilized, especially in combination with most commonly antipsychotic or antidepressive medications, this may be a medication to avoid for that patient. For the last couple of things that we consider prior to transplant, of course, is efficacy. So once we've kind of gone through all of those things, we want to choose the most efficacious product, which for us, we are considering tirzepatide and a GLP-1 receptor agonist first line. Also ensuring that the patient is comfortable with injections versus choosing an oral agent. Then we may utilize phentermine, Contrave, and Qsymia branded products as alternatives. Orlistat and Gelesis 100 are typically our last line agents, as cost and tolerability may impact efficacy. So I do have on the slide here, for example, the Gelesis 100 product is around $100 just for a 4-week supply, which a lot of our patients are likely not able to afford. Something else that we like to consider is what else is needed for listing. So the timing of agent initiation is really important. A lot of our physicians like to say, if the patients have several different things on their list that they need, such as a heart cath or cardiac workup or an echo, or they need to find and identify family support, in addition to weight loss, we may not want to initiate that agent and risk them potentially plateauing or not meeting those criteria and then not getting listed anyways. So trying to find the ideal time to initiate these medications in the setting of all of the other workup that's going on. Dietary counseling is crucial. We have a dietitian that will also meet with these patients, but I think most importantly that when the pharmacist is calling the patient, that we are assessing their diet, what they're doing, how frequently they're eating, are they eating large or small meals on these agents to ensure the best outcomes with these products. And then one thing that we have not yet really found a great answer to, but something we're always thinking about, is continuing post-transplant. I believe we've had about 6 or 7 patients that have been listed and transplanted through our clinic. And we're still trying to determine the best process for continuing these agents post-transplant, when to initiate, and how best to kind of fuel that transition to the post-transplant life. So a lot of these considerations are things we take into account when starting someone on a medication. I have my contact information here, but I'll hand it over to Anicia for her part of the presentation.
Awesome overview, really helpful, and will be really nice to rely upon as we go through my side of the presentation. Can you guys hear me okay?
I can, yep.
Thanks, Mary Grace. All right, so, turn me on. All right, so Mary Grace did a really good job talking about what are the complications that can arise when someone gets a transplant at a higher obesity. With that higher obesity, you know, that really leads different centers to pick different BMI cutoffs. The literature suggests that maybe certain BMIs put people at higher risk, but it really is seen across the board that different centers will rely on different BMI cutoffs. For us at University of Chicago, our kidney transplant program is not transplanting candidates with a BMI greater than 40. Our liver transplant program actually does not have a BMI cutoff, which about 25% of centers do not, and we fall within those centers. Our heart transplant candidates are not transplanted with a BMI greater than 35, and then our lung transplant candidates are not transplanted with a BMI greater than 30. So I think we've kind of alluded to the fact that there's a growing obese patient population, and many of these people have some type of end stage or chronic disease that leads them to eventually or to be currently needing transplant. A lot of centers, as we've mentioned, are turning down people due to that BMI to minimize any complications that can happen post-transplant. And then we've also learned about those novel weight loss medications that have come to market and are promising even greater weight loss and weight management than we've ever seen before historically with medication-assisted weight loss. This all led us at the University of Chicago to develop the birth of a transplant weight loss clinic. So we started a clinic called the Access to Transplant Through Novel Approaches to Weight Loss, also known as the ACT Now Clinic. We opened in March of 2023. March 24th was our first day of clinic. We had 3 patients scheduled that day, and excitingly, we had a whole ribbon cutting ceremony, which was really exciting. And it was fun to have the patients partake and kind of see how excited we were to help people get access to transplant. I want to give a shout out to my coworkers who work very diligently with ACT Now. We have Courtney on the left here. She's our nurse practitioner. We have Jenna Bosnos, who's one of our specialty pharmacists, me, and Annie, our dietitian. So how does this clinic work? What does our workflow look like? First and foremost, we have our patients that are being identified by our transplant providers. That's through when they come through our transplant clinic for evaluation. We accept all organ types into our clinic, but we are relying on providers who are seeing them, typically our surgeons, who are saying this BMI is not compatible with transplant and surgery, so we'd like to refer them to the Act Now clinic. They then place an EPIC referral. From that EPIC referral, it prompts our specialty pharmacies team to do a benefits investigation. We investigate if GLP-1s are approved, and if they are approved, we coordinate delivery of the medication from our pharmacy itself, the University of Chicago Specialty Pharmacy. And then we have the patient scheduled for their first Act Now visit. In that visit, they'll come in person with us. And then from there, as long as we feel that the patient is ready and motivated, we'll schedule the follow-up visits, which will be 2 through 8. At 1 year, we will discharge the patient, particularly if their weight loss has plateaued, or if they've since been on the transplant weight loss, the transplant wait list. But it's important to know that any time within this timeline, if the patient is to meet their goal weight, we are communicating that back to the referring provider and letting them know, okay, now's the time to consider listing our patients. So we will now break this down a little bit further, each step of this process. So a key part of this is selecting the right patients. And for us, we want to make sure that patients who are being referred to this clinic are patients who are desperately in need of an organ transplant, but currently their BMI and weight preclude them from getting a transplant. So we have our BMI cutoffs listed here. We discussed that on our first slide, but it's important to compare that with those who might be inappropriate candidates for the Act Now clinic. These in particular are patients who have an incomplete psychosocial or medical workup. We really, as a preservation of resources, really want to make sure that our patients are appropriate candidates for a transplant. It would be unfair to the patient and to our team to have the patient come in, get worked up, maybe have a pending workup in terms of cardiac workup or unstable support, and the patient be introduced to transplant as a piece of their eval and to help the patient start losing weight, but then they would never qualify. So we want to make sure that their workup is done as much as we can. We also want to exclude anyone who would be malnourished, as we know our GLP-1s can exacerbate this problem. We also we're aiming to exclude patients who are already on a GLP-1, given that this is the kind of the crux of our clinic, but we've become more lenient and we know that lifestyle modifications are a huge piece and starting to accept more people who have historically been on GLP-1s. And then in line with prescribing patterns of GLP-1s, we exclude anyone who has a family history of thyroid carcinoma or MENS type 2. So when that referral should be made by our transplant providers after their transplant workup is complete. We've talked about the importance of making sure that person is otherwise a suitable candidate from a medical and psychosocial standpoint, knowing that the patient is really BMI is what precludes them from transplant. The patient must be informed of the referral by the transplant provider. We feel that's a key step. I always like to think about if I were a patient and I got a random call saying, we heard you need to lose weight, I think that'd be pretty offensive. So we want to make sure that our patients are being educated on the opportunity that is Act Now by their transplant team. We also want the provider to identify an acceptable BMI. We have those cutoffs that were listed previously as guidance, but sometimes, from a surgical perspective, they might be willing to take a touch higher BMI depending on their body habitus. So through that referral, they're able to identify what they would feel is the most acceptable BMI. And then notably, again, in conservation of resources, we are really accepting our kidney transplant candidates to either 1, have a living donor, or 2, have some sizable amount of dialysis time. And that's really because for us, in Chicago, the wait time can be 5 to 7 years for a kidney transplant. And knowing that we kind of have limited resources, don't want to have people who are not yet even on dialysis to come into the clinic and limit our ability to provide for patients who have some dialysis time. Next, we perform that benefits investigation. So we investigate GLP-1 RA coverage, and this is done by our specialty pharmacy team. We test claims semaglutide, liraglutide, and tirzepatide, and we're both testing our induction dosing in addition to our maintenance dosing to make sure that the patient can continue on therapy. For all patients, if therapy isn't initially covered, we attempt a prior authorization and a first level appeal if necessary. And once we see the final price of the GLP-1, if it is covered, we're assessing that for financial assistance. And if there's any ability to add on coupons, go through drug manufacturers to gain access for the patient. Our patients are only scheduled at this time if they have active coverage of a GLP-1 and really want to make sure that that patient is receiving the medication prior to the visit. This often makes the patient really excited and excited to bring in the medication to the clinic. So for that first appointment, our patients are meeting with 3 different team members. First and foremost, they're going to meet with a nurse practitioner who will complete a physical exam along with a medical and family history. And I think one of the biggest parts of the nurse practitioner visit is to talk about readiness and motivation. We do a lot of motivational interviewing and assessment of readiness, and that readiness is a key part in the weight loss journey. If we have to be ready and ensure that we're meeting the patient where they're at to help really establish a partnership and working towards weight loss. When me or Jenna, the other pharmacist that I collaborate with, meet with the with the patient for their PharmD appointment, we will first perform medication reconciliation, and then we'll counsel the patient on what to expect with GLP-1s. Is that we want to talk to them about what are some adverse events that they can expect. What are expectations in terms of weight loss? Is this reasonable? Can we get you here with this medication to where you need to be? What other benefits might you experience from taking a GLP-1, along with administration? As I mentioned, our patients are often bringing their medication into clinic, and they're pretty excited. A lot of times we're injecting first dose in clinic, the patient's doing it themselves because they're so excited to get started. We also spend a lot of time in the PharmD visit talking about movement. I think it's important to label exercise as movement because I think the word exercise with someone with such a significant chronic disease state burden can be really overwhelming. And so we want to relabel and rebrand that movement piece of it to a point that it's a little more approachable. I think this also helps the patient understand that the pharmacist is really focused on comprehensive care and that it's not just about a medication, take this medication, we want you to lose weight. It's really holistic care. We also have the registered dietitian meeting with the patient on the first visit. These are, again, all in-person visits. And the dietitian is going to take a food diary. We have our patients filling out food diaries before they even come to clinic on the first day. And we want to see what their current eating habits are. We then perform individualized dietary modification counseling and really start slow, thinking about what are some easy low-hanging fruit that we can work on from your diet in the beginning and work our way up. Additionally, we rely on an in-body scan that allows our patients to get on a machine that measures both their fat and muscle composition, and we track this over time. For our follow-up visits, we will have 7 additional visits. Notably, visits 2 and 3, which are at week 4 and 8 after initiation, respectively, are virtual. These are just with our pharmacist and dietitian, and the primary focus of this is going to be drug titration, tolerability, and incorporating new dietary changes. The patients like this component of it because it means that they get to have some time before coming back in clinic, and I think the virtual aspect of care was one benefit we saw from COVID. Our subsequent visits 4 through 7, are all going to be in person with the entire team, and they're every 12 weeks. As for those some specifics that we go through during the pharmacist visit, we want to make sure that we're assessing for their adverse effects from the GLP-1. And are those adverse effects that are limiting our dose escalation, or are they something that's manageable and could be treated with medications? We're big believers in, we want to assess how frequent that side effect is and the timeline of that side effect. So if patients are just having nausea for the first 2 days after the GLP-1, a lot of times we'll prescribe ondansetron to help mitigate that, particularly in light of the fact that a lot of these patients are working with limited time given their end-stage organ disease. We also want to assess adherence and access. So as previously mentioned, I'm sure we're all feeling the pain of the GLP-1 shortages, and how do we combat that? And does the patient still have access? We also want to make sure that we're assessing changes in concurrent medications. Specifically, if we think about our lung transplant patient population, it's not abnormal for those patients to be put on prednisone pulses. And is that affecting their weight? Are they interstitial lung disease patients who are on OFEV that's significantly contributing to their diarrhea, and how those might interplay with our GLP-1s? In addition, here's where, like we mentioned, we're addressing that dose titration and our ability to increase the dose in those first initial visits. And then again, goal setting. So talking about those, where do we want to get your weight? How close are we? Reframing it and talking about what are normal expectations to be seen with this weight loss medication, along with changing those movement goals at every visit. In terms of lifestyle modifications, I hope I have some Harry Potter fans in the house, but one thing we really focus on is that really our GLP-1s are our trusty sidekicks. We make a huge focus of this, and I always tell them, Harry would be nowhere without Ron and Hermione, and this is a key part similar to the medications. The GLP-1s would be nowhere without movement and dietary changes. So what's key in all of that is assessing the starting point where you're meeting the patient. So is this someone who, from a movement standpoint, is really sitting around the majority of the day, has a pretty sedentary lifestyle? Or is it someone who's already walking 30 minutes a day and we have to change movement even more? Is it a lung transplant candidate whose oxygen requirement really limits their mobility? And then we're able to set modifiable and attainable goals that change at each visit. From a dietary standpoint, we want to make sure that our patients have access to food. I think this is really easy to forget, focusing on, do these patients have a grocery store that is within driving range or walking range? And can they afford the things that we're recommending, like this lean protein and this green leafy vegetable? Is that something that's doable for the patient's budget? We primarily focus on the Mediterranean diet, but we're pretty open to what works best for the patient. We find the Mediterranean diet is most approachable and easiest for the patient. But if they feel that keto diet or intermittent fasting is something that they want to try, and it would be an acceptable choice within their disease state, we are willing to kind of accommodate and figure out what works best. We do counsel our patients on if they're going to be skipping a meal due to the reduced appetite we see with GLP-1s, to make sure that they're replacing that meal with a protein supplement, like protein shake. And we focus on this to remind the patient that they're building strength for a major surgery. We know that with weight loss comes muscle loss. And so how do we maintain as much as possible and in light of that movement? So again, reassuring the patient, we need you to continue to develop that muscle because you're preparing for a major operation. Here we have some examples of what we talk about in our dietary and RD visits. As you can see, we have a breakdown of what those different topics that can be addressed at each visit. So again, it's a bit more digestible, pun intended, for these patients. We also have example cookbooks that we provide the patients with that we find can be helpful to following the Mediterranean diet. A lot of patients are excited for this new kind of journey they'll start on, and this can be a part of that. We give them codes for imperfect produce so that hopefully this can improve access to affordable food. And then here's a picture of that InBody scan that we're performing to help assess the fat muscle distribution of the patient. From an exercise standpoint, we're using a couple of different handouts. This handout is a branded Act Now handout for yoga. We make sure to include body positive images that help patients realize that sometimes movement can look a little different than what you might see on social media. And then Dr. Look, I would like to give her a shout out from San Diego, helped us develop these seated resistant routine exercises. And we have a lot of patients, we coach them on talking about how can you make this part of your daily life? Can you do seated resistant exercises while the commercials are playing for your favorite show? And we have patients come back and say, I did it for the entire show for a full episode. And this is trackable, measurable progress that excites the patient. So we'll kind of dig into the results of the clinic so far. To date, we have 41 referrals, and the breakdown by organ of those referrals is listed here, with kidney and lung being our highest utilizers of the Act Now clinic. Currently, we have 24 active patients. And when we look at those active patients, this is the breakdown of what they look like. Our kidney transplant population is our highest utilizer at 36%, with 9 of our patients being kidney transplant candidates. And our second highest user, similar to what we saw with the referrals, is our lung transplant candidates. That makes up almost a third of our patient population in Act Now, equaling 8 patients. And then we have 12% of our patients as a pre-pancreas transplant candidate, and 5% being heart transplant candidates. Here we can look at the breakdown of what those patients look like. So we have our average age of our patients is a 49-year-old. Interestingly, it's 50% male, 50% female, which I think is a distinct difference from the majority of the GLP-1 clinics, GLP-1 trials, where those are largely Caucasian and females, both averaging at about 70%. The average BMI at referral is 40.7, and then we generally see a pretty healthy breakdown amongst all of our races and ethnicities. So our largest user is Black at 54% of our patients. Secondly, a third of our patients are Caucasian, and almost 15% of our patients are Latino, which I would say this is probably a pretty fair breakdown of the type of patients in general we're seeing at the University of Chicago. And then we're seeing our patients about 4 weeks after the referral is placed if they're accepted to the GLP or Act Now clinic. Notably, we're only hosting clinic twice a week for a half day every other week, due to the fact that many of us are involved in our own respective organ groups. So finding this is kind of extra time that we're finding. I think this is a heavy question I get amongst a lot of pharmacists, is what the insurance breakdown is. You can see that 41% of our patients have commercial insurance, 17% have Medicaid, and 42% have Medicare. So I think it's a healthy distribution, but I definitely want to echo that with our Medicaid patients, this can be a little bit more challenging to get drug approval. We also have a breakdown of how many patients had approval with no prior authorization, and then those who needed a prior authorization and that it was approved. Here is a breakdown of what generally we're using for our GLP-1. So our highest utilization is of semaglutide, and this would include both Ozempic and Wegovy formulations, Ozempic being off-label, of course. We also are using almost a quarter of our patients are on tirzepatide, and then almost 10% of our patients are on liraglutide. I would say this piece, liraglutide, is generally coming from our Medicaid patients, who this is usually what they have to fail to continue on to other GLP-1 therapy. Excitingly, we've had no discontinuations thus far of our 24 total patients. And when we look at how they're tolerating the medication, I would actually say it's been going very well, which was a big concern of ours in the light of it not being studied frequently in those with chronic end-stage disease. About 12% of our patients are experiencing some type of GI adverse effect, but we see a split between both diarrhea and constipation. The majority of these patients are not requiring any type of pharmacological therapy like loperamide, and the majority of this is not precluding us from dose escalations. Excitingly, all of our patients are losing weight, which we're super pumped to see. Of the 13 patients who have completed 12 weeks of ACT now, and I picked that number because that's generally how long it would take to see lifestyle changes, is generally about 12 weeks is what the data shows us. The average weight loss from patients in the ACT Now clinic is 18.9 pounds, and there's a range of 7.9 to 27.9 pounds. So this is incredibly exciting for us. 5 of our patients, of those 24, have reached our goal weight, and 3 patients have been subsequently listed. So we're excited and we're ready for our first patient to get transplanted who got on the transplant wait list from ACT Now. We definitely are aware that there are a lot of limitations of this clinic. I think some of our biggest concerns include, what do formulary changes to people's insurance plans look like over the next few years, and our ability to maintain our patients on their current therapy, or ability to add new patients to the clinic itself. Additionally, as mentioned previously, those medication shortages, how we continue to combat the GLP-1 shortages. Are we able to provide equal access amongst different insurance providers? You guys saw that our Medicaid patients don't have access to those therapies that provide more promising and robust weight loss, and how do we justify that moving forward? We also want to think about, as previously mentioned, what does therapy continuation look like peri-transplant? Some of those patients will be hospitalized for a really long time, like our heart and lung transplant candidates. And how do we continue GLP-1s or reintroduce GLP-1s post-transplant? And then something we haven't faced yet, because we haven't hit the 1-year mark, is how we will discharge patients who are stable, and what will it be like to have those conversations with primary care about accepting the responsibility of continuity of care of those GLP-1s. For our future endeavors, we hope to expand this access to living donors, and living donors being able to utilize our weight loss clinic to then give to their loved ones. We also hope to expand this across Chicagoland and teach other centers how to do this. Hopefully partnering with GLP-1 manufacturers to expand access to transplant, and thinking about how do we gain patients more drug coverage. If the insurance doesn't cover, can we partner with a GLP-1 manufacturer to give them medication free of charge? We also hope to apply for a grant to teach other centers across the country how to start their own ACT Now clinics, and ultimately publish our ACT Now data. Here are my references, and we will start take any questions. I think there's one in the chat.
Yes. Did you get one directly to you? Or to me? Okay, you can go with the one that's directly to you first, if you want to read. Yeah.
Okay, cool. So Diana said, wondering how you set up the weight loss goal. Are there risks to losing weight too fast? Do you stop at lower dose or increase or ongoing increase to the recommended dose once reached? Okay, I'm gonna go question by question. Wondering how we set up the weight loss goal. Yeah, great question. So we want to think about what for us, we want to think about what that goal BMI looks like for the patient that's told to us by the provider. For us, in early titration stages, even if the patient's losing no weight for the first 8 weeks, we really want to be positive and tell the patient, we know that primarily our weight loss is going to be seen when we hit goal dose. So we want to proceed with precaution, but we also want to think about what's the timeline that the patient has. Are they someone who is really, really on 6 liters of oxygen and really cutting it close to losing their candidacy for lung transplant? And then we might be a little more aggressive with our weight loss goal. But generally, we just know that we want to get the patient there within somewhere between 3 to 6 months. Are there risks of losing weight too fast? Yes, I definitely say that patients can become malnourished from losing weight too fast. We don't see this too often, and this is the reason we'll be a little bit slower with our titration. I know some people will start Ozempic or Wegovy at 0.5, but we're starting at low dose to ensure that we're not leading to that. And then do you stop at lower dose or or ongoing increase to the recommended dose. So it's patient specific if we continue to increase the dose. If the patient that's twofold. If the patient has a lot of time to go, like they're on the they need a kidney transplant, but maybe they only have 2 years of wait time, we might wait for them to plateau at their current dose in terms of weight loss before we allow for dose escalation. Once that plateau in weight loss is seen, then we'll bump them up. For our lung transplant candidates, because their time is so limited, we might be regularly increasing them. The instance in which we're not increasing people to maximal dose would be if they've already met their goal weight at the dose they're at. We definitely are just keeping people there and seeing where they go, given it's usually still pretty early. And then we are not tapering the dose down once they meet goal weight, given the severity of the implications if they were to gain weight and subsequently fall off the wait list. I hope that answered all your questions. Thank you. Those are awesome questions.
Thank you so much. A few more questions in the chat. First, do you have a plan for how to manage these medications post-transplant when your first patient gets to transplant?
Yeah, great question. So I hope that day comes soon. We've met with all the teams and asked if their providers are willing to take on prescribing afterwards. For our cardiothoracic teams, that was kind of a no-brainer for them. They act more as primary care providers long-term for both our lung and heart transplant teams. So they're pretty willing to take on responsibility of prescribing drugs that are not just transplant specific. With our kidney transplant patients, we don't have a lot of liver transplant candidates. We don't have any actually due to not having a BMI cutoff, but for our kidney, I think that will be a little more precarious to see what happens. We are focused on getting people onto the wait list. So in theory, they should not be coming back to us post-transplant. But I think, the realistic point of it is we don't want them to gain weight. So it's common for our center, over 50% of our kidney transplant patients need insulin post-transplant, even if they didn't need it pre-transplant. So we do have a partnership with endocrinology, and we're hoping that with kidney transplant recipients, they'll be able to continue on their GLP-1 therapy through endocrinology.
Okay, great. I think there's a few questions with plans for holding and resuming immediately post-op, and then also the logistics of continuing agents for particularly the lung transplant population inpatient with formulary restrictions.
So for kidney, it's a little bit easier because they usually are leaving post-transplant pretty quickly before even their next dose is due. In terms of lung and heart, they definitely are staying longer, and we're thinking about what that looks like. I think, generally, if your admission is about 14 days for heart or lung transplant, I think that's an acceptable amount of time to stop off GLP-1 therapy. There's a lot of things going on, so we're okay with holding and maybe restarting at half dose is what we've talked about, or maybe a little bit, or reintroducing the medication a little bit slower as they come back onto therapy as an outpatient. We haven't broached the subject of making these formulary inpatient, but my guess is that our inpatient formulary team will feel that that's the best idea. So I think there's still a lot to work through. Was that all the questions? I'm sorry.
Yes, I think that was all the ones specifically related to that question. Sorry, I tried to group the ones we could.
No, it's right.
I think everyone's really excited about these agents.
Yeah.
And then another question is, who is involved in the referral for the clinic? Is it a surgeon, and do they ever prefer to use the waist to hip ratio over BMI?
Yeah. So I would say it's typically our surgical team that's referring our patients, and particularly in the abdominal sphere. Our pancreas and our kidney transplant surgeons are doing a lot of the referrals. In heart transplant and lung transplant, it often is actually our medical colleagues who are doing the referring. Our lung transplant team have really helped with buy-in, and they've been incredibly supportive. So that has led a lot of them to refer early, given that a lot of our lung transplant candidates are very sick. And so we want to help be able to do the most amount of lifestyle modifications. For kidney transplant, there even are some candidates who are getting referred before they even meet with the surgeon if their BMI is incredibly high, like 50, 55, so that we can start the process and they're simultaneously scheduled with the surgeon. In that the surgeon can kind of decipher if this person could be a candidate long-term with weight loss or if their medical complexity rules them out. In terms of using waist to hip ratio, I would say we've actually had an influx of new medical and surgical leadership where our BMI goals are changing. So we are seeing some patients really enter evaluation and maybe even get listed with BMIs greater than 40. And we're kind of trying to reestablish in the kidney transplant patient population what that looks like, what will be the cutoffs, but there is more discretion being used.
Great. Thank you so much. And Mary Grace, is your practice overall pretty similar, or do you have any different experiences with holding or resuming the medications post-transplant?
Yeah, I think everything that Nisa said, we do a lot similarly, but we do have experience with post-transplant. So I think we've had, I want to say 6 or 7 people who have been transplanted as a result partly of our clinic. And then typically what we do is if the patient, once they get to transplant and are in the hospital, we first assess how much medication they have at home. And then on the discharge trajectory, when the pharmacist is educating them, if they're going home on insulin or if they're not, regardless, we will ask them to hold typically it's a GLP-1, but we've had some patients on phentermine and topiramate. We'll ask them to hold their agent until the transplant team asks them to resume that. And what that means is then the inpatient pharmacist is sending a message to the outpatient transplant clinic pharmacist, letting them know that this patient will need to be reassessed for resumption of their weight loss medication. And then usually around the 1 month mark, we're sending a message both to the liver transplant team, which then also includes our liver. Typically it's more of our livers, but our metabolic weight loss team, asking when we feel it would be best for them to reinitiate, based on how they did post-transplant, if they had complications, if they're able to tolerate the mycophenolate dose that they need to be on, and all of those things kind of going together. We have a discussion, and then if the patient should be reinitiated, in our experience, most patients have needed to be reinitiated, whether it be to decrease insulin requirements or to prevent weight gain. I can think of one patient in particular who is now starting to gain weight again because we weren't able to initiate his Mounjaro right away because of tolerability. So usually the 1 month mark is when we're assessing if okay to initiate. And then the transplant pharmacist in clinic in combination with the provider is initiating. We do all the titration, we as the pharmacist. And then we try to coordinate, kind of like Anissa said, with endocrinology long-term or their primary care doctor to take over management once we've titrated them to either their previous dose or their current new max tolerated dose.
That's great. Thank you so much. And then last question is for Anicia. With starting this clinic, how did you get your team to buy in to having your presence in clinic? And also, what is your schedule like? Is it, a morning session, a couple days a week? Could you just describe?
Yeah, awesome. Yes, this was an extreme challenge to get provider buy-in. We initially the dietitian and I came up with this idea. We're very close friends, and then worked on this and presented it to administration in June of 2022. And I will say, even getting a meeting on their calendar took about 2 months. And it was met with a lot of people saying, oh, but there's this issue, where would we find the staff? Where would we find a coordinator? And we kind of just kept pushing through. We had the luck of our medical director of the lung transplant team change, and she really thought that this would be an enormous opportunity. Our lung transplant program is pretty small. So we have 7 people who were transplanted for lung transplant last year, and we've added 3 people to the wait list. And she was a big believer and knew this would increase the lung transplant volume. So she really advocated for us. And I think that was really a big key, is like finding who are key stakeholders. I think we really thought that this would help the kidney transplant patient population the most, because we feel there's a lot of obesity in that patient population. A lot of the lung literature focuses on patients who are underweight, not as much overweight. And we really met a standstill with kidney. There was a lot of staffing concerns. And so we kind of went through a different avenue. I think that's the biggest key, finding out who might be your unexpected, appreciated stakeholders. And from there, we really hit the ground running, but we had to make a few bargains. I would say we do not currently have a coordinator, so it's really depends on the nurse practitioner. It's kind of a team effort. We're all constantly reviewing the queue, looking for refills. So it's pretty time intensive, I would say. And then in terms of how many times we have clinic a week, so we do clinic on Tuesdays and Fridays. I would say if you're going to start this clinic, you want to make sure that you're picking 2 different days, thinking about people's dialysis schedules. So you don't want to do Monday, Wednesday, and Friday. You want to incorporate a day that would allow for both types of dialysis shifts. So we picked Tuesday and Friday, and we picked that according to when the least amount of people were in clinic so that we could use rooms. And we do 2 half days a week. So we do 8 to 12 twice a week, every other week. And that every other week was solely picked to be able to allow us to have some reprieve given the volume and the fact that each of us work on our respective organ team in both the inpatient and outpatient setting. That answer your question?
Yeah, sorry for the technical difficulties, but I think that's it for the questions, unless anyone has any last second ones. With that, I wanted to just take the time to thank all of our attendees today for coming and for taking the time out of their busy lives and on a Saturday, and give a special thanks to all of our speakers as well for coming to kind of share your expertise and your experiences with so many different topics. Just some reminders for those who came today. In order to claim your CE credit, you will be getting an email to the email that you used to register for the Zoom with instructions on how to do so. It is a little involved and it requires making you an account on the Rush CE website. And then after that, we'll kind of give you instructions on how to claim credit for each one of the talks today. So with that, thank you again to everyone, and we hope you have a great rest of your Saturday. Bye-bye.